Good afternoon. Thank you for joining today's webinar on the future of Medicaid State Directed Payments. My name is Jen Colomanico, and I'm happy to be your moderator today. Before we get into our panel, I just wanted to highlight a few things. This is the first in a series that we'll be doing over the summer with all of what has already been changes to the Medicaid program, proposed changes, as well as more that we anticipate coming on this front. We will be having a series of conversations. So today we'll be talking about state-directed payments. We will have conversations in July around community engagement work requirements, and in August around program integrity. And in there somewhere, there may be other changes that come along as was designed in the original bill last year. So we are just trying to stay on top of all of this and help you make sense of it. So you will have an opportunity to register for each of these webinars and encourage you to do so through the QR codes or through our follow-up. And also just wanted to point out, because it's always the first question that we get, that yes, this webinar is being recorded, and yes, these slides will be shared. So you can look for those in a follow-up email after today's event. If you have questions, we will have about 15 minutes at the end for questions. Please post them in the Q&A box at the bottom of your screen. So with that, let me introduce our tremendous panel that we have today. Okay, Rob Buchanan is a senior principal at Health Management Associates, and he helps public agencies, health plans, and providers improve healthcare delivery and outcomes through Medicaid payment, policy, reform, and system transformation. He brings deep expertise in Medicaid waivers, value-based payment models, and services for high-need populations, including reentry programs that support individuals transitioning from incarceration back into the community. Mary Gutierrez is a principal at Health Management Associates with more than 15 years of experience in Medicaid financing and provider reimbursement. She has worked with government agencies, hospitals, health systems, and other providers across more than 25 states to develop and implement Medicaid funding strategies that support access to care for Medicaid and uninsured populations. And finally, Robert Ross is a managing director of finance and operations at Health Management Associates and a seasoned healthcare executive with deep experience and expertise leading hospital transformation, financial turnaround, and system integration efforts. He has guided safety net providers through major strategic initiatives, including hospital mergers, operational improvement programs, and large-scale delivery transformations to improve access, quality, and long-term sustainability. So those are our experts, and we're excited to jump right in. So first, I'm going to turn it over to Robert for an overview of our topic today.
Great. Thank you, Jen, and thanks to all of you for joining us on this webinar. Before we get started, we do want to note that these proposed rules are still open to interpretation and could change based on new guidance and final rulemaking from CMS. The state-directed payment proposed rules published by CMS last month detail the implementation of the SDP changes contained in H.R. 1, which was passed July 4th, 2025. These proposed rules are not exclusively a methodology for implementing H.R. 1 SDP changes, but rather a broader redesign of state supplemental Medicaid reimbursement to providers. The key components we will discuss today are: one, the restriction of most payments to 100 or 110% of Medicare rates. Secondly, freeze of existing payments above the new Medicare rate limits, and the mechanism that CMS will use to transition those rates down following implementation. And third, the additional restrictions on Medicaid payments that go beyond those that are contained in H.R. 1. Next slide, please. The state-directed payment proposed rule alone represents a significant Medicaid payment reduction to providers, far exceeding what Congress anticipated when it passed the underlying legislation. The Congressional Budget Office estimated the impact of H.R. 1 on SDP would be $149 billion through 2034. CMS estimates with these proposed rules that the government will save $510 billion, more than 3 times the cut expected based on the legislation. The divergence is due to the broader impact of the proposed rules expanding payment limits beyond the 4 provider types that are included in the legislation and new restrictions on other forms of Medicaid supplemental payments. We'll discuss our insights on how states, associations, providers, and payers can prepare for the impact of these proposed rules later in the presentation. But first, let's dive into the details of the proposed rules, and for that, I'll turn it over to my colleague, Mary.
Thanks, Rob. So we're going to walk through the four components of the proposed rule. Although you're here to hear about SDPs, we will touch on at the very end, just for a minute, the targeted provisions related to the targeted fee-for-service payments to practitioners. Next slide. The reconciliation legislation limited SDPs to a percentage of Medicare, which varied depending on if you were an expansion state or not. Expansion states are limited to 100% of Medicare and non-expansion to 110%. One main question coming out of that reconciliation legislation was, how is CMS going to define what the Medicare equivalent payment level is? In this proposed rule, they are defining it as the actual published rate by service, which means to calculate the new limit, states are going to need to reprice Medicaid claims and discharges at service-specific code levels. They do define that Medicare published rate as including all add-on components. So rates are very specific to a provider's service offerings, patient mix, quality outcomes, and geographic area. For services where there is not a published Medicare rate, the limit will be the Medicaid state plan approved rate, meaning the fee-for-service rate that excludes any supplemental payments. Next slide. As we noted at the beginning, CMS went beyond what was called for in the reconciliation language, and these new limits apply to all state-directed payments. So the reconciliation language only explicitly included these four services outlined on the slide: inpatient, outpatient hospital services, professional services, and nursing facility services for the new limit. Because these services were included in a 2024 Medicaid managed care final rule that explicitly codified those services as having an average commercial rate ceiling for payment. But now CMS is going beyond what was in that reconciliation legislation and explicitly lowering the payment ceiling for every SDP service to a percentage of Medicare. It's also important to note that the Medicare ceiling by service extends to any value-based payment. So even if a payment is designed as prospective and population-based, they would still need to be reconciled back to ensure that no provider received more than Medicare for any service, even including that incentive-based payment. Okay, next slide. The Medicare-specific limit definition using the service-specific limit specifically goes beyond what many had imagined the reconciliation language to imply, and definitely goes beyond how things operate today. One big concern is the administrative burden these calculations will require to develop. Often Medicaid pays on a significantly different structure than Medicare, which is going to require that states and their actuaries create very complex crosswalks of individual services provided under Medicaid to Medicare rates. And we'll go into examples of this complexity in a moment. The service-specific limit will also limit states' ability to target payments under the Medicaid managed care program. Currently, states are able to set higher payments for services if they think that they're critical to the needs of their residents. Since Medicare and Medicaid serve very different populations based on who's eligible to enroll in each program, there's likely services that aren't as prevalent in the Medicare world, like maternal health, that could see decreases to reimbursement under this approach. It would also limit a health plan's ability to negotiate higher rates as they're developing adequate networks. Another big concern is that this deviates from the payment limit that we see for the same services under Medicaid fee-for-service. Under fee-for-service, states are allowed to pay a reasonable estimate of what Medicare would pay at the aggregate level rather than the service-specific level. For example, for inpatient hospital services, Medicaid fee-for-service could be limited to cost since Medicare reimburses for some services on a cost basis. And that would be the limit, the aggregate limit for all inpatient hospital services for a group of, let's say, private hospitals. But Medicaid managed care would be limited to something below that. This could potentially create an incentive for states to transition some services back from Medicaid managed care to Medicaid fee-for-service just to get more flexibility for the payment structure there. Okay, next slide. On this slide, we're showing some examples of the misalignment between how Medicare pays for services versus how Medicaid pays for services. Probably a lot more examples, but just to give you a taste of it. Inpatient hospital care is a very clear example. Although states may use DRGs as the basis for billing inpatient hospital services, how they group those services into DRGs and the levels of reimbursement may differ significantly from Medicare. Medicare reimburses for DRG codes using the MS-DRG grouper. This grouper was developed for adult patients, and it's related to resource intensity by procedure. On the Medicaid side, many states utilize a different grouper, the APR-DRG grouper, which was developed for all age groups and was designed to incorporate the severity of illness and risk of mortality into reimbursement. States often choose this approach because they think it better aligns with their Medicaid population, and this would require them to crosswalk that back to the MS-DRG. Another example is cost reimbursed providers. Some providers are reimbursed under Medicaid, or cost reimbursed under Medicaid, which is especially common with government-owned providers. If Medicare pays on a different basis, any directed payment would then be limited to the Medicare rate rather than cost. So Medicaid has decided that cost is the most appropriate level of reimbursement for the specific provider. Under a Medicaid or under a state directed payment, a state would not be able to do the same thing. They would have to go by whatever Medicare pays. Then just in general, there's services like types of long-term care that are covered by Medicaid but not by Medicare. These would now be limited to Medicaid fee-for-service rates because there are no Medicare published rates for these services. Okay, slide 11. Okay, so we try to illustrate how this methodological change is going to result in a lot more administrative burden for states. So in the top chart, we're showing a very simple example of what an ACR calculation, average commercial rate calculation, may look like for a state-directed payment going to 3 hospitals. In this calculation, we're comparing the average commercial rate ceiling with what Medicaid actually paid for those hospitals to determine the gap. In this example, it's $10,750. And hospitals share in that distribution of the gap, regardless of how they contributed to it. So regardless of how their payments compared to average commercial rates. This is done in part so that hospitals that were able to negotiate higher rates don't also only get the benefit of that. So the smaller hospitals, the more rural hospitals that might not have that negotiating power get to share in that, the average commercial rate ceiling calculation. In the lower chart, instead of this calculation with just the 4 rows, the 3 hospitals plus the total row, the state would need to calculate the difference between Medicare and Medicaid's rates for each individual service. So there's over 700 DRG codes in the MS-DRG grouper. So that would mean this calculation would require more than 700 lines per hospital for each of these hospitals to cover all of the DRGs. Under this approach, each hospital would also only be eligible for receiving the difference between their own Medicare rate and what Medicaid paid. And this could lead to a significant redistribution of the benefit, which we'll talk about more on another slide. Okay, next slide. So to sum up this section, we wanted to pull some of the big impacts into 3 categories: providers, health plans, and state Medicaid agencies. On the provider side, we would see less ability to negotiate rates above Medicare, a potential redistribution of the benefit within the SDP program, and overall just reduced revenue due to the cuts to from ACR to Medicare levels for states that are currently paying at or near the ACR for services. For health plans, this will impact the provider network development and maintenance and may require additional infrastructure to align Medicaid reimbursement with Medicare. For Medicaid agencies, the big impacts are the administrative complexity and repricing claims to Medicare, downstream effects this may have on Medicaid enrollee access, and the greater influence of Medicare policy on Medicaid reimbursement, which means the loss of some state autonomy under the Medicaid program. Next slide. All right, jumping to the next section, the reconciliation language allowed for some existing SDPs to be grandfathered in and allowed to transition down to Medicare levels. This would apply to preprints submitted before July 4th, 2025. The passage of the reconciliation language has to be for one of the 4 outlined services and apply to one of the rating periods shown on the slide. Another big question coming out of the reconciliation language was how would CMS define that 10% phase down? CMS proposes in this rule to define that as 10% of the grandfathered amount. So this would mean a constant dollar amount loss each year because that 10% will be pegged to that initial grandfathered amount. For example, if an SDP was worth $1 billion that was grandfathered, then it would need to be reduced by 100 million every year until it reached that Medicare ceiling. And this phase down begins for rating periods. So that means when the Medicaid managed care contracts start, rating periods beginning on or after January 1st, 2028. Okay, next slide. Because each SDP is in a different starting place relative to Medicare levels, the 10% reduction to the grandfather payment is not going to be a uniform phase down across different SDP programs and across states, but it could last anywhere between 1 to 10 years. As you can see on the charts on the right, it could look different, but once the SDP is lowered to Medicare levels, different rules will apply. You can stay at that Medicare level, so it'll be somewhat constant. You could see a growth in Medicare payment levels, which would allow some growth in the SDP program, but different rules will apply, which we'll discuss in a few slides. Some were hoping for a different application of this 10% reduction based on some ambiguity in the language in the reconciliation legislation. Some were thinking maybe the 10% could mean how much above Medicare your SDP was and reducing that by 10% every year. This could have resulted in a more prolonged phase down for some states, but CMS chose what seems like the most straightforward and likely the fastest transition methodology. For other services beyond the 4 called out in the reconciliation language, there will be no transition period. So they do get an extra year, so it won't the changes won't impact them until rating periods beginning on or after January 1st, 2029. But at that point, you need to come into compliance and be at that no more than that Medicare percentage of Medicare level. Some remaining questions that I still have on this phase down methodology. How will CMS treat SDP programs that include services from both the list of 4 that would be grandfathered and others? Some health systems might have inpatient, outpatient hospital payments in their SDP, but then they might also include ambulance services or other physician services. And it'll be interesting to see how that is kind of teased out when right now they're kind of all together on one preprint, which authorizes the whole program. If a state has multiple SDP programs for the same universe of providers, so if you had a uniform rate increase, but also you had a value-based payment program, it's unclear if those each need to be reduced by 10% annually, or if there's flexibility in reducing just the uniform rate increase by what would be the equivalent of 10% of the total, if that reduction can be spread across the different programs differently, or if it has to be 10% of each one. Okay, next slide. The one bright spot, I think, for providers in this rule is the temporary relief on some of the 2024 Medicaid managed care final rule provisions, which include the prohibition on retrospective changes to preprint submission, which will go into effect absent this rule July 9th of this year, and the prohibition on separate payment terms, which goes into effect July 9th of next year. Separate payment terms are a structure by which a state can pay the health plans outside of the capitation rate payments for the SDP program. This is typically used for programs that have a fixed pool of dollars and or a fixed uniform add-ons. So that doesn't need to get intermingled with the PMPMs paid to the plans. States may prefer separate payment terms because they allow them the transparency to confirm that all the payments went out to providers in the appropriate manner, and the retrospective adjustment allows them to make revisions as actual utilization is known. CMS knows that they're proposing to pause these requirements until the end of an SDP's phase down so that they can better enforce these limitations on grandfathering, making sure that states are not going above their grandfather limits or their phase down grandfather limits, and to better track spending. Next slide. So for providers, the 10% reduction definition getting some clarity on that from this proposed rule will allow them to have better estimates of the impacts of these reductions, but it may also speed up the phase down compared to other potential interpretations of what that 10% would be. Reducing the payments from close to or at the ACR will also result in significant reductions to Medicaid managed care reimbursement for many providers. For health plans, pausing some of the 2024 rule requirements may help reduce the complexity of implementing and complying with these other SDP changes, so kind of spreads out the changes over more years than having them all kind of happen at once. And for Medicaid agencies, the 10% reduction calculation is simple and predictable, but the devil may be in the details there when SDP programs that include multiple services may need to be broken apart. Okay, next slide. For both new SDPs and ones that have completed the phase down period, the rules around allowable SDP structures will change significantly. So in the future, SDPs will no longer be able to take the form of uniform add-ons to claims. They'll only be able to be structured as value-based payments or minimum or maximum fee schedules. Going further, when setting a minimum fee schedule, today states are able to just point back to their Medicaid fee-for-service fee schedule and say, CMS, you've already approved this under our state plan. We're just going to match it under Medicaid managed care. Under this proposal, despite CMS determining the rates were appropriate for these services under fee-for-service, states will still need to demonstrate that those rates do not exceed Medicare levels by service. Then finally, the pause on the prohibition of separate payment terms will end, and this will require a significant structural change to a large number of SDPs and will introduce new levels of risk for health plans and providers that may require the implementation of things like risk corridors. Okay, next slide. To try to help illustrate the difference between a uniform add-on distribution and a minimum fee schedule distribution, we've included two charts so that these might not seem like very different. You might say if everyone under a preprint is getting a 10% increase to payments, their base payments today, how different is that than changing the minimum fee schedule to just include a 10% increase to payments? It will have very different results in the distribution of payments across providers. So on the top, each provider would receive a uniform percentage increase to their base payments, resulting in the relative distribution of that SDP in the far right column. On the bottom chart, using a minimum fee schedule approach where each provider is limited to their Medicare-specific service rates, providers will only receive the gap between what Medicare pays and what Medicaid pays. So this example shows that provider A was receiving in the top chart 25% of the SDP under the uniform distribution, but they now get 67% under the minimum fee schedule distribution. Provider B would not even be eligible to receive an SDP under the minimum fee schedule because their Medicaid rates already match Medicare. So this redistribution of the benefit across providers could have unintended impacts to access. So it's a kind of shuffling of the money in a different way. Okay, next slide. The big impacts for this section to providers are the removal of the ability to structure payments using uniform add-ons and removing the ability to utilize separate payment terms, which will introduce new risk to the program. For health plans, again, aligning to the new provider payment structure rather than having some ability to negotiate provider rates will be may be administratively burdensome and impact the ability to create adequate networks. They will also see new risk with the removal of the separate payment term structure. For states, developing and enforcing minimum fee schedules will require additional ongoing administrative burden, especially as Medicare rates are updated annually. Removing separate payment terms will remove a level of transparency into SDP program that states have today and potentially add risk to the states as well. Okay, next slide. All right, and just to cover this piece quickly, because it is fee for service. CMS is also making some analogous changes with this rule to fee-for-service targeted practitioner payments. So historically, states have been allowed to target payments to certain practitioners up to the ACR. With this rule, CMS is now changing that limit to 110 or 100 and 110% of Medicare, same as with the SDPs, starting with the state fiscal year beginning on or after January 1st, 2029. This only applies if the state targets certain subgroups of practitioners and does not apply to any service that falls under a fee-for-service UPL calculation, like inpatient and outpatient hospital services. So this only applies if it's from this group of practitioners that are defined on the slide, and if it's just a subgroup within that definition. Okay, so now I'll turn it over to Rob to talk through what comes next.
Great, thanks, Mary. What comes next? So we've got some key dates to throw at you. Next slide. Thank you. First, July 9th is important because that date from the 2024 Medicaid Managed Care Rule limits states' ability to make retroactive changes to SDP preprints for rating periods beginning on or after that date. The proposed rule would not apply that restriction during the SDP phase-down period. Next up comes the July 21st deadline to submit comments on the SDP rule itself. This will be the primary opportunity for stakeholders to provide feedback before the rule is finalized, and no doubt CMS will be getting a lot of feedback. Beginning January 2027, states would need to submit the Medicare payment limit demonstration for rating periods beginning on or after that date. So this is where the detailed financial and policy analysis that Mary has been discussing becomes especially important. July 9th, next year, is another milestone from the 2024 rule. For rating periods beginning on or after that date, states can no longer make SDPs using separate payment terms, again, as Mary discussed, although the proposed rule would not apply that restriction during the phase down. The major inflection point, again, is January 1st, 2028, when the phase down begins and the new SDP limitations start to apply. And then finally, beginning January 1 of 2029, SDPs for services beyond hospital inpatient, outpatient, nursing facility, and qualified practitioner services at academic medical centers must be reduced to the 100% or 110% Medicare ceiling, and targeted fee-for-service practitioner payments must also be reduced to those Medicare levels. So while some of these dates may seem far off, they establish a relatively short runway for analysis, engagement, and planning. Next slide. We also want to point out that the regulatory landscape continues to evolve as stakeholders consider these timelines. Just consider that this proposal, this SDP rule, is just one piece of a broader and evolving Medicaid policy landscape. As we noted, the comments to the SDP rule are due July 21st. For organizations affected by these changes, it's an important opportunity to share data, operational considerations, and policy concerns before the rule is finalized. But there are also several related rule-making efforts to watch. As many folks know, last week CMS published the interim final rule related to Medicaid community engagement requirements for the ACA expansion population. In addition, the proposed provider tax rule and the proposed, it's a mouthful, strengthening the integrity of Medicaid and CHIP managed care, financing and access to care rule, both of those remain pending and could be released at any time. The latter of which specifically references state-directed payments in the notation in the Federal Register. So, taken together, all of these suggest that the Medicaid financing policy environment will continue to evolve beyond the proposed SDP rule that we've been discussing. Next slide. So what should stakeholders be doing now? Well, for states, the priority is understanding how the Medicare-based payment limits and phase down provisions affect SDP programs and provider funding streams. This will require provider level modeling to identify where funding reductions may occur and which providers, particularly including Safety Net and other Medicaid dependent organizations, which would face some of the greatest exposure. States will also need to evaluate implications for provider sustainability, access, and healthcare system stability. For payers, much will depend on how individual states are affected and how they respond. Plans should be monitoring state policy decisions and assess impacts across their provider networks and markets, including potential impacts on rates, provider reimbursement flows, network stability, and administrative requirements. State approaches emerge, payers can begin evaluating some of the implications for contracting, payment operations, reporting, and compliance. And lastly, for providers, the starting point is really to understand SDP exposure. Organizations should quantify reliance on SDP funding and identify which facilities and programs may be most affected. We recommend scenario-based financial modeling to help estimate reimbursement, margin, and operational impacts under the different payment assumptions, and that will help inform your advocacy, strategic planning, and organizational response. So across all stakeholder groups, I think the common theme here is the need for some fairly rigorous analysis. Organizations need to begin evaluating their exposure, which will really help be better positioned to respond as the rulemaking process moves forward and some of these implementation requirements become more clear. With that, I'll turn it back to Jen for our Q&A session. Thank you.
Excellent. Thank you all. You moved quickly, so we have a lot of time for questions, which is great. So first of all, somebody just noted here that the AHA and most state hospital associations will be providing model comment letters, and lots of letters would be useful. So just to keep an eye out for some help in providing comments and feedback within the windows submitted, but that some of those associations would provide some initial guidance, which
Jen,
is
can
a
I
great
just
call out. Please,
can I
yeah.
just add to that? I just want to implore that, as we've said multiple times during this presentation, that CMS has gone beyond what was mandated in the legislation last year, and these changes that are included in the proposed rule, namely the service-specific Medicare limit, limiting other SDPs outside of those 4 to Medicare limits, and then going to the fee-for-service, limiting those down to Medicare. So all those pieces are kind of from interpretations that CMS took from what their mandate was from the reconciliation legislation. So there should be room for movement without requiring congressional action. This is about interpretation of these rules. So it's really important, if there's things in here that are concerning to you, to make comments because they really do matter here.
Yeah, great call out. Just a quick question. What does WFTC stand for? I think there's been several names for this legislation, if I'm not mistaken.
Yeah, I can answer that. So you might have known it as HR 1 or the One Big Beautiful Bill Act. Since they started working on actually implementing the changes in that, they've kind of retroactively made the change to calling it the Working Families Tax Cut Act. So if you know it better as the One Big Beautiful Bill, that's what we're talking about. It's all just different names for the same thing.
Great. Yes, the slide deck will be shared after the call, so I can take that question. Okay, let's go back up to the top. So there was a question earlier on in the slides. Does the VBP, value-based payment provision, also include contracts between MCOs and providers that are negotiated separately from any state direction?
It's a good question, because They do explicitly say in the preamble to the rule that any negotiated provider rates, so if you have a negotiated base rates, would be included in that comparison to Medicare rates. I would assume that that also means any value-based payment rates, but maybe if they're not tied to a specific service and just overall incentive payments under your contract, then potentially they could be carved out, but I think that is kind of a gray area.
Okay. Okay, a couple questions about managed care. So you had mentioned, Mary, that incentives states may have to move some services from managed care back into fee-for-service. So if you could just sort of talk a little bit more about your reasoning or your thinking about that.
Yeah, just a basic example is for hospital services, Medicare may be paying for some services less than cost. So cost is a legitimate what am I trying to say? Justification for paying for creating a payment level under fee for service. So a state can say, we're paying for this hospital service at cost. We're showing you that that is a reasonable estimate of what Medicare would pay because Medicare pays for some things at cost. So under fee for service, that's allowed. That's under the upper payment limit calculations that there's much more flexibility in targeting specific services to be paid higher rates, as long as in the aggregate, you're under some payment limit ceiling. Here, you're really just limited to whatever Medicare decided was the appropriate rate for that service. So you wouldn't have any flexibility beyond that. You wouldn't be able to target specific payments to specific types of services. So that might lead states to realize that they have more flexibility to make more decisions about designing the payment model under fee-for-service rather than managed care. It's not to say that CMS isn't going to the next step, say, okay, now we're going to crack down on fee-for-service and apply the same kind of limits. But right now, as this proposed rule stands, there would be a much less flexibility for how to design payments under Medicaid fee-for-service than under Medicaid managed care than under Medicaid fee-for-service.
Okay, so it contributes to that trade-off, carve in, carve out kind of thing. Okay. Okay, a couple questions about provider impact. So first of all, if this goes into effect as drafted now, which as you've said, it may go through some changes, but if this goes into effect, would you anticipate a decrease in hospitals who accept Medicaid managed care?
I don't know about that. I mean, I think it's still be hard to turn away patients and contracts, but there is less right now with these ACR payments much higher than Medicare levels in place today. There's a huge incentive for states, for providers to kind of even fight over Medicaid patients, which has not been the case in the past. And this would really get rid of those incentives. So maybe more begrudgingly, I don't know if that would go to the extent where they would stop accepting Medicaid managed care.
Just jumping in, I would agree with you, Mary. Most safety, almost all safety net hospitals, academic medical centers take all the Medicaid managed care, which is mandatory or in most states. So I would expect that it wouldn't change, but it'll be interesting to watch, especially as you said. There's not a lot of negotiating room the way the legislation is, the rules are currently written. But we are seeing more hospitals dropping Medicare Advantage plans around the country. I don't think the same thing will happen with Medicaid, but something certainly to keep our eye on.
Thank you. And as I was going to say, I took down the slide so everybody can see all of you. Feel free to, any of you, to jump in or add on to answers. Okay, the next question. Will the limited fee-for-service targeted practitioner payment reductions / restrictions even the playing field with managed care? Will there be less of an incentive for states to move some services from managed care to fee-for-service? Maybe the flip side of the earlier question.
Yeah, for those specific services, potentially, there still would be the flexibility if you're not going to target payments within those categories. So if you wanted to increase all physician rates above what Medicare pays, you'd be allowed to do that. It's just this rule, the limit would only apply if you start to say these specific physicians would be eligible for an increased payment over all other physicians. That's when you'd be limited down to Medicare levels. But if you're not making any targeted payments, you'd still have more flexibility on the fee-for-service side than on the managed care side.
Opinion comment, but certainly sounding like this means less money all around for providers and managed care plans. So will there be enough competent providers left after the rates are cut like this? How much will access be an issue? So any of you certainly weigh in on the impact on access.
Yeah, Rob, do you want to go on this one?
Yeah, we already know there's access issues with Medicaid, around the country, and there's providers that don't accept Medicaid, and this only exacerbate that issue as there's downward pressure on the rates. So, it'll likely impact access in areas that are already challenged in access. So we would expect to see that.
Yeah, and I think that CMS might say that these payments have gotten so big over the last few years that it's kind of still new money. Do hospitals or other providers really depend on it? But I think just thinking through everything else that's going on in the country, just with the impacts of COVID, prices kind of went up for everything and never really went back down. And so the cost of everything is going up. It's hard to keep, like the question said, it's hard to keep providers, quality providers. Some of this money was helping to improve the quality of care at different providers because it goes beyond just giving payments to providers enough to survive and gives them more rates that maybe go up to costs, or it allowed for more investments in the services, and potentially those will go away without this funding.
And also to remember that this is just one aspect, and there's other parts that are occurring, and certainly we're going to see community engagement work requirements have an impact on access as well, and we're already seeing the impact on access for the reduction of the ACA subsidies and an increase in the uninsured. So that all plays in. They're all interrelated, of course.
Yeah, I would say I think certainly all providers will be impacted, but the safety net providers in particular, it's a little bit of a 1, 2, 3 punch with so much happening at once. And I know a lot of organizations are just struggling to keep up with the pace of the changes that are coming. But I do think that there's a potential for this to be financially destabilizing for safety net providers. And as a result, I think the considerations around access are important questions to ask. And I don't know that we have, I don't know that we can quantify that today, but I do think that that is the natural kind of next question to much of the changes that are occurring.
There's 2 questions about litigation. Do we expect this to result in litigation? I feel like the answer is probably always yes, but probably have a more nuanced answer to that.
Yeah, I think there's definitely been rumblings of litigation. We're not lawyers, but I think that there have to be some strategy around when does that come in. Since this is a proposed rule, do you focus on doing the comment period, or do you just go straight to litigation? There's been some questions about how the scoring of this rule is so different from what was in the reconciliation bill, if there's some legal question there. But yeah, I think that's definitely on the table right now, because people are taking this very seriously.
There's a couple questions about sort of the impact on fee-for-service versus managed care, whether it would be have bigger impact on one or the other. I don't know if you can address that.
Yeah, I think, as we keep saying, that there could be a reason for states to now look back to fee-for-service and try and maximize reimbursement there, which would mean reimbursement could potentially get higher on the fee-for-service side versus the managed care side. I think as states have been moving more toward managed care over the last 10 years, the fee-for-service side has been less of a focus. It's been trying to maximize payments under managed care because that's where most of the volume is. But I think now providers and states are going to be looking at every corner that they can to see where they can maximize reimbursement to try and recover some of these potentially lost dollars.
Okay, lots of great questions. Isn't it the case that the expansion in state-directed payments to new service types and application of fee-for-service are not largely responsible for the much bigger savings estimates, but rather CMS's own assumptions about the unmitigated growth of SDPs compared to OMBs? Any thoughts on that?
Yeah, I think that's probably a fair point. I think there's no detail. Well, there is detail in this rule around how much they're saying is related to the SDPs that they were cutting in the reconciliation versus the new categories and the fee for service. But I think part of the increase to the number is that there were some states that saw increases to their SDPs right before that July 4th deadline of last year when things got kind of frozen in place. So those weren't included in the numbers that the CBO was working with, but then they did get in under the wire to be grandfathered in. So that also raised it. And when you just take that out multiple years, then that grows to be a big number. So it's a lot of different pieces that are all adding into the difference in the scoring.
That makes sense. Could you reflect on how this highly restrictive proposed rule adversely impacts the use of provider tax financed and IGT financed SDPs in the future?
Yeah, right now, with a lot of these big programs are financed through provider taxes, which means a tax on the healthcare services that get used to help generate funding for the Medicaid program. These providers will agree to these taxes because it does create a large net benefit to the industry. As the taxes have to be broad-based, meaning they cannot be a tax on Medicaid to fund Medicaid. It's a tax on their full book of business. But generally, if every provider is receiving a benefit from the program, if they provide any sort of Medicaid service, they're receiving this add-on payment, then the industry can generally support these programs because it brings more money into the industry, and generally everyone, as long as you're doing Medicaid, you see a benefit out of it. This could create situations with this minimum fee schedule approach where a provider could have no room to receive a new payment. No matter how much more Medicaid they do, they're already being paid at Medicare rates. They don't get any extra benefit from this program. So it could create reasons for the industry to no longer, or to be more divided, to not support these programs. Potentially that's CMS's goal, is that they've signaled that they don't love these provider tax programs, and maybe this is their way of making them seem less palatable. But I think that potentially there's ways to try and figure out ways to make them still sustainable, but it's a little early to understand the full impacts of that, especially waiting for the provider tax rule to come out as well.
So a couple questions around sort of the downstream impact. So the impact on hospitals and other providers is clear. Is there a sense of the impact of the cuts to non-OBBBA services like behavioral health, home community-based services, et cetera? What's the potential to cut or limit optional benefits or eligibility groups? And then there was another question that I think is sort of related, which is, were they assuming that the RHTP funds were going to kind of help fill in some of these gaps? And kind of, what's the thinking on the connection to these other services that are supported by these payments?
Yeah, that's a good question on the other services. So I think it's unknown exactly how it's going to impact each individual type of service. I think a lot of times those other services have things like alternative payment models. So an alternative fee schedule or an alternative way to pay for services by maybe some sort of bundling, that it'll be interesting to see how that would compare to a Medicare reimbursed system and what the difference is there. It's hard to know exactly how big those impacts are going to be, but they'll probably vary greatly by different types of service.
So you mentioned value-based payment principles. There's a couple questions about that, and I, it's worth saying that this administration has been bullish on value-based payment in different ways in terms of some of the support. So, one question is that the proposed rule seems to run counter to value-based payment principles, including for quality and delivery system reform incentives. So this person is saying after the grandfather period is essentially a reconciliation to a Medicare fee schedule. Is there an opportunity to advocate for an exemption or different approach for value-based payment SDPs? And so I guess maybe broaden that to kind of, is there a repurposing or refocusing some of this stuff on value-based payments as an alternative here?
Yeah, I think the reconciliation language didn't specifically speak to value-based payments, so there is room to kind of say, should these be treated separately? It really does, in my opinion, it's disappointing to see that because everything's going to be reconciled to at most Medicare rates, then there really is less incentive to create these value-based payment programs and to put in effort into achieving the targets. So yeah, I think that's definitely a place that providers should and state agencies and other stakeholders should comment on.
I just wanted to also comment and agree with Mary's point there. To me, to reconcile to Medicare rates would potentially undermine value-based payment programs for quality or other kind of performance incentives. So I think that that's a very to the extent people are kind of sizing up what their comments might be, I think that is an important kind of consideration to include in your comments as you're thinking about how to respond.
Great. Question that says, how would this impact a hospital that is not paid APDRG, but rather per diem?
It depends. So if you're talking about on the Medicaid side versus Medicare side, if you're paid a per diem under Medicare, then that would be the measure against which your SDP potential would be. That's what you would measure against. So for the different types of reimbursement that providers get, they'll match exactly what Medicare pays you. They're not going to lump all hospitals into the DRG system if they're not paid that way by Medicare.
Somebody was asking for this Federal Register citation, so I don't know if one of you has it handy and could drop it to the, we could send it in the follow-up email as well, but maybe perhaps drop it in. So let's see. What is the timeline for Medicare ceiling rates at the service level be available for modeling purposes?
So states will need to submit something for their contract period beginning in 2027, calendar year 2027 to CMS. Based on this proposed rule, they're saying that's the deadline for the state submitting this payment comparison for their SDPs. So states are going to need to start working on this right now and trying to figure out how to do this crosswalk. So that'll be the first time that something is required from CMS around this.
Okay. A couple broader questions that I think are interesting. One person says, like, what's the case against this SDP change, given that it was supposedly used to improperly inflate payments, right? Perhaps that's the allegation. So how plans and hospitals respond to that? And then, well, maybe I'll just pause there. And any thoughts or comments on that?
Yeah, I think that's going to be a very state-specific, provider-specific argument to make, but some general pieces that I can add in is that by limiting all providers to this Medicare level could have unintended consequences, like for rural providers, if they're potentially paid up to cost on Medicare right now, being part of these programs could give them benefits beyond that. So they're kind of taking the room that's being added to the potential for spending from other hospitals and redirecting that towards the rural hospitals or rural providers of any kind. So under this, that would be taken away. So you would not be able to take some kind of payment gap room that's created by other hospitals and target that to hospitals or other providers that are in the most need of additional funding. So I think that there's ways that, so with HR1, they're obviously trying to just reduce these payments in total, but I think that the way it's being done in this rule is so inflexible, so strict that there could be these unintended consequences that say, even if you think that these payments should be reduced, this is going beyond and probably hurting some of the providers that you're trying not to hurt.
I would have to agree, Mary. And whether there's an argument on the methodology, it's the net effect of it that it's reducing Medicaid payments, which are frequently already lower, and it would have an impact. So just reducing the payments is not necessarily the solution to a challenge or a problem.
Is a question that I have to say the thought crossed my head as I was my mind as I was listening to you talk about this. Is aligning or sizing everything to Medicare kind of a backdoor to a single payer approach? I'm quite confident that is not the intent of this administration, but it is kind of interesting. Any thoughts about this kind of alignment to Medicare?
Yeah, I think that that's kind of a talking point that could be used against this, is that right now the Medicaid program is built on the idea that states should be able to design their own program to deal with the needs of their states and the population, their residents. And this is saying that Medicare at the national level is setting payment policy and everyone needs to follow that under the Medicaid program as well. So I think that it's taking a lot of the autonomy away from the states, a lot of the flexibility to design the programs in the way that your state's the best, what you need the most. It's taking that away and kind of letting Medicare influence all of those decisions. That could also mean that in the future, there's going to be much more advocacy towards the Medicaid program, trying to increase reimbursement because it has the effect of also increasing the Medicaid reimbursement. So there could be new ideas that are coming to Medicare and being pushed for that were kind of not thought of before because it wasn't a focus for the Medicaid program as well.
Right. One question here I think is important to point out. This person says, if the House or Senate flips to Democrat, does that create a path to cut back some of this and cut back some of the OBBBA? But, I think more broadly, do you take this seriously? I'm sure there may be institutions out there saying like, this will get litigated or this will get overturned or, thoughts on, it's like you got to walk and chew gum, right? Like, so how do we think folks should be responding and how confident should they be that this would be thrown out at some point?
Yeah, I'll jump in and then, Mary, Rob, please jump in. We hear a lot across the country of folks thinking that this won't be implemented the way at least the rules were and that it's a wait and see. We would strongly advise to take it seriously at its face, and as Rob mentioned in that last slide, do the preparation, understand its impact, understand if it's in whole or in part enacted the way the proposed rules are. What are your advocacy points and what is your mitigation strategies? So, we strongly advise to take it seriously and don't. It may change, especially if there's changes in November in the House or Senate, but to take it seriously and prepare.
Yeah, I would fully agree with that. I mean, I'm just thinking back to some of the policy changes around the enhanced premium tax credits, and everybody was sort of taking a wait and see attitude on that, thinking, well, that won't happen, and it did. And I hear this a lot on kind of all the rules that are coming out is, well, maybe we'll just wait till the next administration and something will change. I don't know that we can rest on. I mean, it's not a strategy that I think is worth pursuing. It's important to kind of be mindful and be acting here.
Yeah, high risk certainly there. All right. Well, we are just about at time. There are definitely some questions we didn't get to, so we'll look through, and if you put your name in there, happy to follow up with that. And please follow up with questions. Obviously, any of these three folks, as well as the teams behind and alongside them, are ready and willing and able to help with all the things that we talked about today. Lots of planning and strategizing, and maybe you plan and strategize and then it's all for naught, but at least you were ready. So always important in business. So appreciate all of your wisdom today, and thanks for everybody joining in. We'll be back next month with our next chapter, and who knows what else will hit the agenda between now and then, but no shortage of things to talk about with regard to Medicaid policy this year. So thanks everybody, and we'll see you soon.
Thank you.
Thank you.